This is Dr. Jeff Klauser, and this is my technique for repair of a medial meniscus root tear. This patient is a 60-year-old female with long-standing right knee pain that has failed conservative care. The patient was indicated for a medial meniscus root repair after preoperative MRI demonstrated an avulsion of the medial meniscus root. After diagnostic arthroscopy is performed, I use a curette to debride the medial tibial plateau in order to decorticate the medial tibial plateau for later healing. Once the scar tissue is taken down and the medial meniscus root is mobilized, I then make a separate incision just medial to the tibial tubercle. A drill guide is then inserted and the medial tibia is drilled up until the tip amer is hit. Once the amer is hit, the drill is removed. The sheath is then left in place. A passing suture is then passed through the sheath. This will then be used to shuttle the sutures for later fixation. A first pass mini suture passing device is then inserted through the medial portal, and a looped mini tape suture is then passed. The free end is then placed through the loop, and this is then cinched down for a locking type stitch. A second suture is then used and passed further medially. The two sutures passed adjacent to each other will act as a ripstop. I also ensure that I pass the sutures medial enough in order to get to good strong tissue, as when pulling the tissue down through the tunnel, you have to apply significant traction in order to gain good fixation and a stable repair. Once the sutures are securely passed, I will then grasp both sutures as well as the passing wire through the medial portal. This will ensure that there are no soft tissue bridges when shelling the sutures. Alternatively, you can place a cannula through the medial portal to ensure that there are no soft tissue bridges. I will then shuttle the two sutures through the looped passing suture. They're then pulled down through the medial tibial tunnel and placed under tension in order to ensure adequate reduction as well as suture fixation. Final tensioning will be done with the knee in 90 degrees of flexion. With the knee 90 degrees of flexion, the meniscal repair is under maximal tension. These sutures are then passed through a button. I prefer a button over footprint anchors. However, that can also be used in order to secure the final repair. I use a knot pusher while securing the sutures over the button. That enables me to use a tiny little incision. And I also feel that I'm able to tension this down more securely with the use of a knot pusher. Once tied down, I will check it with a probe to ensure adequate tensioning. I will take the knee through a range of motion as well. Post-operatively, the patient is non-weight bearing for 6 weeks. They are initially placed in a hinged knee brace, locked in extension. Physical therapy has begun, and a slow, gradual return to full range of motion is undertaken. Given the non-weight-bearing status, the patient will also be placed on anticoagulation for DVT prophylaxis